So now I welcome Dr. S.K. Sharma, another doyen of endocrinology in Rajasthan. We know that he is a teacher for all of us, and he has taught every single person about diabetes and thyroid. So I have with me another very senior physician, a very well-known person, Dr. Sriman Sahu, whom I request to introduce Dr. S.K. Sharma, please, and his topic.
Thank you.
Dr. Sharma, I request you to just make it quickly because I am seeing Dr. Anil Bansali also. He has joined in. He has his next lecture.
Thank you, Dr. Manawat. It is a great opportunity and privilege for me. And I don't think I have to introduce Dr. Sharma because everybody knows in our country, and he has such a personality. And you see, he has done the, as Dr. Jordia is saying, that education is the most important aspect in diabetes management. He has conducted more than 350% education programs. So you can know that he has almost more than 35 years of clinical experience and very renowned endocrinologist in Jaipur, practicing in Jaipur, and he is a member of APICON, ADA, then ESICON, RSSDI, ASD, and he has organized so many conferences, and he's a very good speaker, and he's a advisor of multiple programs, and he is a excellent teacher. When I started my diabetes career in my basically I'm an anesthesiologist, but I switched over and started my diabetes practice 12 years back, and I listened to him, and I was really very much impressed. And I don't think he has to be introduced, everybody knows. So let us start. Dr. Sharma will talk about SGLT2 inhibitors. We have now listened about the recent insulin, but now SGLT2 inhibitors, they are very good drugs, very excellent, and when we are unable to control with others, he has a vast experience of 5 years experience of this SGLT2 inhibitors, empagliflozin. We'll talk about that. Listen to us. So over to Dr. Sharma. Thank you, sir.
Thank you, Dr. Sahu. Om Shanti, and good evening to all my friends. Show my screen. I'm not able to see the sign of share your screen. Dr.
So your screen is already been shared. You can start your PowerPoint presentation now, sir.
No, I am not able to. My screen is already shared. Okay, yes, so can you see my presentation?
Yes, sir. We can see your presentation now, sir.
Make a slideshow. That's perfect.
Okay. So thank you, Dr. Minawat, for inviting me for this. You can say webcast, our scenario. And good evening to all my friends. My job is to look into the 5-year experience of empagliflozin after the EMPA-REG outcome trial. So dear friends, when we are talking of diabetes now, we are not talking of hyperglycemia only, but we are talking of many more things like accelerated atherosclerosis, coronary artery disease, nephropathy, heart failure, etc. So you can see here that progression of cardio-renal metabolic system is there in our diabetic patient. You may start your journey with risk factors like diabetes, hypertension, obesity, and dyslipidemia. Our patients are developing endothelial dysfunction. They have accelerated atherosclerosis. They develop coronary artery disease, myocardial infarction, then followed by left ventricular remodeling. There is an increased risk of heart failure in our diabetic patient and ultimately death. On the other hand, these patients are developing endothelial dysfunction, microalbuminuria, increasing to macro, then chronic kidney disease, and end-stage renal disease. So you find so many risk factors are there, looking into both cardiac, renal, as well as metabolic outcome in our patients. Important point is that if you look into intensive control of hyperglycemia and looking into all these landmark studies like UKPDS, ACCORD, ADVANCE, and VADT, we find that microvascular complications are definitely reduced, but there is a very limited effect on macrovascular complication by achieving a tight control of hyperglycemia. Similarly, intensive glycemic control is not able to achieve a reduction in hospitalization for heart failure and fatal heart failure in all these landmark studies. So diabetes is a independent risk factor for heart failure, irrespective of whether the patient is having ischemic heart disease or not. Our diabetic patients are going to develop a diabetic cardiomyopathy and heart failure. Multifactorial management of cardiovascular risk is very, very important. We are not only looking at glucose profile, but also looking at, you can say, blood pressure lowering, lipid lowering, and individualized therapy, and diet and exercise, and stopping smoking. All these things are required, which was highlighted by Steno-2 trial, where we can provide maximum benefit to our patients of diabetes. Many of our drugs are very effectively reducing hyperglycemia. Some drugs are causing hypoglycemia like sulfonylurea. Other drugs are causing weight gain like pioglitazone and sulfonylurea. But there are few drugs like SGLT2 inhibitors, which are not only having good glycemic control, do not cause hypo, they do cause some weight reduction, and they have a favorable blood pressure lowering effect and lipid lowering effect. So if you look into comparison of empagliflozin and sitagliptin at various baseline of HbA1c, whether it is 8, 9 or more than 10, you find that reduction in HbA1c is far, far better with empagliflozin as compared to sitagliptin. And with every 1% increase in baseline HbA1c, the corresponding HbA1c reduction with empagliflozin is something like 0.49, and with sitagliptin it is only 0.29, indicating there is a significant anti-hyperglycemic efficacy of empagliflozin as compared to sitagliptin. Empagliflozin is significantly improving time in range. Now we measure this time in range in looking into glycemic profile of our patient. 10 milligram and 25 milligram of empagliflozin in day 1 and in day 28. If you look here, you find that the time in range, that is the time spent by a patient in between 70 to 180 milligram, is very, very significantly improved in patients who are on empagliflozin. Empagliflozin as compared to glimepiride not only effectively reduces hyperglycemia but also causes weight reduction. As compared to that, glimepiride causes weight gain. So there is a more or less 5 kg weight difference between these two in studies which is lasting for 2 to 4 years. Empagliflozin, we know that it is a SGLT2 inhibitor, causes more, you can say, loss of glucose in urine. But indirectly, there is some, you can say, advantage. It improves the beta cell function also. The disposition index, that is insulin secretion and insulin resistance ratio, is significantly improved when the patients are given empagliflozin. Not only that, it is having anti-inflammatory effect. In addition to reduction of insulin resistance, you can find that insulin resistance is reduced by 42, and hsCRP is also reduced by 54% when the patients were on empagliflozin. Fat is an important component. NASH is an important disease now in Indian context, as well as our diabetic patients are having 70% chance of having non-alcoholic fatty liver disease. So empagliflozin here you can see is acting at liver, muscle, and causing a significant improvement. Particularly, it is converting white adipose tissue to brown adipose tissue, which is causing more thermogenesis and energy expenditure. But at liver level, it is causing decrease in lipogenesis, increasing beta oxidation of the fat, and reverting and NASH in our patient. So there are trials where they looked into in this EMPA-REG outcome, empagliflozin trial by the name of E-LIFT, the study which was done comparing with placebo in patients of type 2 diabetes with NAFLD. You find that there is a significant 5% reduction in liver fat in patients who are on empagliflozin as compared to placebo, and all the components, whether it is steatosis, lobular inflammation, hepatocellular ballooning, NASH resolution, fibrosis, and fibrosis resolution, all are improved when these patients were on empagliflozin as compared to placebo. New onset of obstructive sleep apnea is also significantly reduced in patients who are on empagliflozin as compared to placebo. So here you find there is a 52% relative risk reduction of development of obstructive sleep apnea, which is again very commonly seen in our obese patients and in our diabetic patients. So empagliflozin in patient with type 2 diabetes and nocturnal hypoglycemia, where it is uncontrolled, you find there is a significant nighttime, daytime, and 24-hour systolic as well as diastolic blood pressure reduction with empagliflozin. And here you can again see morning home blood pressure reduction is significant in systolic and diastolic when the patients who are uncontrolled hypertensive, now when they are given empagliflozin as an anti-diabetic drug, there is a significant improvement in their blood pressure profile also. Empagliflozin significantly improves the albumin-urea. Urinary albumin-creatinine ratio is significantly reduced. Patients with microalbuminuria, there is a 32% reduction in urinary albumin-creatinine ratio. Patient with macroalbuminuria, 41% reduction. So very effective. This is a you can say cartoon which is explaining the effect of SGLT2 on erythropoiesis. When the patient is healthy, once the person is healthy, you find that very little amount of glucose is going into the proximal convoluted tubule. Most of it is reabsorbed there, and you find that there is a very little amount of ATP spent there. As compared to that, in the middle panel, you can see in patients with hyperglycemia, in diabetes, there is a large amount of glucose which is absorbed by the proximal convoluted tubule, requiring very high ATP consumption, and it is causing a significant stress and a atmosphere of hypoxia, leading on to release of inflammatory cytokines, and thereby the fibroblasts which are secreting erythropoietin are stopped secreting it. But once we give SGLT2 inhibitor, then you find that large amount of glucose is you can say lost in the urine, proximal convoluted tubule are not working excessively, and erythropoietin secretion improves, and that's why hypoxia is significantly relieved. Sodium SGLT2 inhibitors are also elevate the renal stress responsible for sympathetic activity, or you can say activation. So here what happens, because of increase in hyperglycemia, you find that there is increased sympathetic activity because of stress at the level of kidney, which lead to tachycardia, increased peripheral vascular resistance, and high blood pressure. But once we reduce this stress with the help of SGLT2 inhibitor like empagliflozin, then everything reverses. Empagliflozin, as compared to glimepiride, when added to metformin, is preserving the estimated GFR fall. So as compared to glimepiride, where the red line is indicating that there is a gradual fall of estimated GFR, you find that empagliflozin is preserving the estimated GFR and preserving renal function. Empagliflozin demonstrates 82% greater likelihood of sustained regression of macroalbuminuria in EMPA-REG outcome trial. So effect of these drugs at the level of micro and macroalbuminuria is very, very significant. We all know that in EMPA-REG outcome trial, there was 38% reduction in the renal relative risk reduction of cardiovascular death, and the two you can say line started separating very early in the follow-up of these patients, and this reduction in cardiovascular death was observed in all the categories, whether it is fatal MI, fatal stroke, heart failure related death, or sudden death, or presumed cardiovascular death. So dear friends, there are large number of cardiovascular outcome trials with SGLT2 inhibitors. Some were done on 100% patients with pre-existing atherosclerotic cardiovascular disease like EMPA-REG outcome and VERTIS trial, but other were having a combination of high-risk patient and pre-existing atherosclerotic cardiovascular disease. But when you look at the major adverse cardiovascular event, MACE, these are significantly reduced in most of these studies with SGLT2 when the atherosclerotic cardiovascular disease was present at the baseline, but they were more or less neutral when there was no atherosclerotic cardiovascular disease. So benefit of MACE was seen in pre-existing cardiovascular disease patients. And here you can see that it is the EMPA-REG outcome trial with empagliflozin, which is the only trial reducing cardiovascular death by a tune of 38%. As compared to EMPA-REG outcome, you find that this figure was not achieved by other SGLT2 inhibitors trial. Heart failure hospitalization was improved. Both group of patients were pre-existing atherosclerotic cardiovascular disease and no atherosclerotic cardiovascular disease, and renal composite endpoint were also significantly reduced by most of the SGLT2, whether they have a pre-existing cardiovascular disease or not. So renal outcome, benefit outcome, and heart failure hospitalization was irrespective of the atherosclerotic cardiovascular disease. So in EMPIRE reduced trial, which is a landmark trial after the DAPA heart failure trial, which was done on patients of type 2 diabetes as well as type non-diabetic patients, where the you can say they were having reduced ejection fraction, and these were the patients both in diabetic and non-diabetic group, and cardiovascular death and heart failure hospitalization was reduced to a tune of 25%. And you find that first and recurrent heart failure was also reduced to a tune of 30%, and the estimated GFR slope was significantly stabilized by patients who are on empagliflozin as compared to placebo. So this study, which was done on reduced ejection fraction patients of diabetes as well as normal, you can say non-diabetic patient, showing that this group of drugs are also helpful in reducing hospitalization for heart failure, whether the patient was having pre-existing heart failure or not. So here you can see most of these patients were on pre-existing heart failure in these two trials, EMPIRE reduced and DAPA heart failure. And SGLT2 inhibitors are also reducing to a tune of 58% renal events as compared to DPP4 inhibitors. So comparison of DPP4, which are more or less neutral as regards renal outcome, here you find there is benefit of empagliflozin. So dear friends, we started our journey with cardio, renal and metabolic aspect. We traced the patient's development from endothelial dysfunction to myocardial infarction, left ventricular remodeling, heart failure and microalbuminuria to renal failure. And you can see that these group of drugs are looking at most of the aspects, like they are controlling the risk factors, they are reducing the events in patients with cardiovascular disease pre-existing, they are reducing cardiovascular events in patients who are having pre-existing or not, and they are reducing myocardial infarction, they are reducing hospitalization for heart failure, and they are also reducing you can say renal impairment in our patients. And because of this, since 2016, when all these outcome trials started rolling out, you find that the change in the criteria of using these drugs were changed, and you find that whether it is ADA, ESD or European Society of Cardiology, all are highlighting that these are the group of drugs which are for glycemic control, for cardiovascular and mortality benefits, for benefit in patients who are having pre-existing atherosclerotic cardiovascular disease or having chronic heart failure, or those who are having diabetes or no diabetes but CKD. And you find that independent of atherosclerotic heart disease, these drugs are having benefit in reduction of hospitalization for heart failure and providing renal benefit in that way. And you find that now is a time of personalized management of these patients. We look at the patient's characteristics, whether he is having simple hyperglycemia or having established cardiovascular disease, where we prefer drugs which are decreasing major adverse cardiovascular events and cardiovascular mortality, like empagliflozin. If the patient is having heart failure, decreasing heart failure hospitalization by SGLT2 like empagliflozin. If there is chronic kidney disease, again we can use this group of drugs like empagliflozin or other SGLT2. Even in these trials, patients who are having more than 75 years of age were enrolled, and here we find that empagliflozin can be given, as you find that DPP4 inhibitors are considered to be safer in our elderly patient. In obese type 2 diabetic patient, these drugs have additional advantage of causing weight reduction like GLP-1 and SGLT2. And in NASH, you have drugs like pioglitazone, SGLT2 inhibitor and GLP-1 decreasing the NASH in our diabetic patient as well as non-diabetic. So ADA-SD in the last, you can say 2020 guidelines highlighted that the patients with metformin and lifestyle look at the characteristics of the patient. If they are having pre-existing or having high risk of atherosclerotic cardiovascular disease, CKD or heart failure, we give them either SGLT2 inhibitor or GLP-1 receptor agonist. If there is compelling need, we have this 4 group of drugs. If you want to reduce the weight gain or promote weight loss, we have again GLP-1 and SGLT2 inhibitors. And for cost constrained persons, we can use sulfonylurea and pioglitazone. So these are the guidelines directed therapy which we are using. And here again, ADA says that for cardiovascular effect, these group of drugs like empagliflozin, canagliflozin are very helpful in patients of atherosclerotic cardiovascular disease. And for heart failure, all these SGLT2 inhibitors are there. And European Society of Cardiology highlighted that even as a primary or monotherapy, if the patient is drug naive and they have this atherosclerotic cardiovascular disease or they are having high risk for the development, you can start therapy with SGLT2 inhibitor or GLP-1 receptor agonist. Or if they are on metformin and they have these characteristics of atherosclerotic cardiovascular disease or high risk, you can again add SGLT2 or GLP-1 in this patient as a second line drug. So again, all these guidelines are telling us that a recommendation for glucose lowering, all these SGLT2 inhibitors and GLP-1 receptors are there. And for reducing cardiovascular outcome, class 1 recommendation for reducing the risk of heart failure hospitalization in patient, you can see here again SGLT2 inhibitors are highlighted. And in the end, anti-hyperglycemic therapy in our patients with CKD, here we are giving metformin and SGLT2 because this group can be given safely. Once estimated GFR goes below 45, we don't give metformin. If patient is already on metformin and he goes below 30, then we stop metformin. SGLT2 earlier recommendations were for 45 estimated GFR, but now with this trial where lower and lower patient, you can say estimated GFR below 30 was included in these trials, now we are confident that these drugs can be used even up to a estimated GFR of 30. And then of course other drugs like DPP4 inhibitor and glitazones can be used. But once we are using these drugs, we have to have carefulness that these drugs do have some side effects and they do have some contraindications, and all this should be looked into. So in summary, we can say that our diabetic patients are not only hyperglycemic, but they are having high risk of development of cardiovascular disease and renal disease, and holistic management is required. Personalized medicine approach is required, and the group of drugs like SGLT2, like empagliflozin, are very useful in reducing MACE. They are very helpful in reducing hospitalization for heart failure, and they are providing, you can say, benefit in our cardiovascular patients as well as renal patients. So they retard the, you can say, kidney progression also. So I can unshare my slides now. Thank you very much. Yeah.
Thank you very much. Such a wonderful and a quick presentation, which has made it very clear where exactly to place SGLT2 with or without metformin. And certain new information about anemia, about obstructive sleep apnea, which are not really usually discussed because we keep on discussing only diabetes and we don't really discuss effects other than hyperglycemia, have been pointed out so wonderfully well. I'm sure all my clinician friends will be benefited with what I've been told today. Dr. Sahu, if you have any question, very quick question, because we have the next panelist, next speaker already on board. So if you have some question, can you please put forth? Can you unmute, Dr. Sahu?
You can unmute, sir. Short question and short answer.
Yes.
I hope I have not taken more time, sir, than what is prescribed to me.
The most you have been really in time.
Yeah.
I think he has not been able to unmute. So thank you very much, Dr. Sharma, for the wonderful lectures.
Thank you, Dr. Sahu. Thank you, Dr. Vinod. Thank you. I will be listening to Dr. Bansali.
Yes.
Can I ask one question, sir?
Yes, go ahead, sir.
Yes,
go
sir.
ahead.
Why not? Why not?
Sir, this drug now initially meant for endocrinologists or diabetologists, then hijacked by cardiologists and now nephrologists. Who, in your opinion, is going to take over this drug?
We will not allow cardiologists or nephrologists to hijack this drug. In fact, what we are going to do is we will be using this group of drugs very early, and we will be preventing the development of
Yes,
cardiovascular
exactly,
disease and
exactly.
nephropathy. And that's why our cardiologists and nephrologists will be having less work in the future.
Right. Because they already say it is a beta blocker of chronic kidney disease.
No, we will not give this drug to them, and in fact, we will reduce their burden of cardiovascular disease and
Exactly.
nephropathy. Right from beginning,
Agree
we
with
will
you.
be using these drugs.
Well said,
Thank
sir.
you
Well
very
said.
much, sir.
Thank you.
Thank you.